Okay, guys, can we start the cornea quiz discussion? Okay, so the first question from yesterday's cornea quiz. Which of the following has the best prognosis for keratoplasty? See, keratoplasty is a very, very important topic. Keratoplasty means corneal transplantation. Good morning, Vinod. Good morning. Yes. So, which has the best prognosis after keratoplasty? So, option A, keratoconus. Option B, uveitis. Option C, atopic conjunctivitis. Option D, glaucoma. See, when a patient already has glaucoma, yes, increase intraocular pressure and all, may not have the best prognosis after keratoplasty, because after keratoplasty definitely you have to give the patient topical steroids, and topical steroids are going to increase the IOP. Yes, and if a patient has pre-existing glaucoma, I don't think that's a great situation, yeah, to be in. Atopic conjunctivitis, again, atopic conjunctivitis, there is a lot of inflammation on the ocular surface. So the graft may not be doing well after a keratoplasty. So again, not great situation. Uveitis, you got so much of inflammation, and keratoplasty, no, not a good prognosis. Keratoconus, see, keratoconus has an excellent prognosis after keratoplasty. So when you're doing a corneal transplantation for keratoconus, you can either do a penetrating keratoplasty, that is a full thickness keratoplasty, that is you remove all the layers and replace it with the donor cornea, or you can do partial thickness. So if it is partial thickness for keratoconus, what do? We do a DALK, deep anterior lamellar keratoplasty. What is deep anterior lamellar keratoplasty? You don't touch the posterior lamellae at all. Okay, you stick only to the anterior lamellae. So that means you are not going to touch the duas, the decimates, or the endothelium. So we are going to replace the epithelium, Bowman's, and stroma. Yes, anterior lamellar keratoplasty. Now, when I say deep anterior lamellar keratoplasty, we are going to remove deeper layers of the stroma, more than half of the stroma. If I limit myself to less than half the thickness of stroma, then that would be superficial anterior lamellar keratoplasty. So for keratoconus, either you do a full thickness keratoplasty, especially when there's a lot of stromal scarring and decimate membrane tears, or you do a DALK. Yeah, that also works. Now identify the limbal stem cell marker. See, limbal stem cell marker ABCG2, which is option A, ABCA4, APCA4. So our answer is ABCG2. ABCG2 is a limbal stem cell marker, right? Now what is APCA4? APCA4 is a gene which is mutated in case of Stargardt disease, the macular problem. Yes, the macular dystrophy. Then AQP4, aquaporin 4. Aquaporin 4 is involved in the pathophysiology of neuromyelitis optica. Yeah. So in your Devick's disease or neuromyelitis optica spectrum disorder, there are autoantibodies against aquaporin 4, right? Okay. Next, endothelial plaque is seen in Pseudomonas keratitis, Acanthamoeba keratitis, Aspergillus keratitis, mycobacterial keratitis. See, the concept here is so we know it's all corneal ulcer keratitis, that is there in the options. So the concept is this organism has to penetrate the decimates membrane, which is a very strong resistant layer, and reach the endothelium and form a plaque there, endothelial plaque. So which organism is capable? Yes, very good. The fungal keratitis, the fungal hyphae are capable of penetrating an intact decimates membrane. Okay, so there is no need for perforation for it to go to the endothelial side. So the concept is fungal hyphae penetrate intact decimates membrane. So they're able to reach the endothelial side and grow over there like a plaque. So the answer is fungal keratitis. So in this case, which is a fungus? Is it Pseudomonas, Acanthamoeba, Aspergillus, or Mycobacterium? It is option C, Aspergillus keratitis. Okay. the only FDA approved drug for fungal keratitis? There is only one answer. What is the drug of choice for fungal keratitis? Okay, what is the see, there are two questions to this. What is the most common cause of fungal keratitis? And therefore, what is the drug of choice for fungal keratitis? What is the most common cause of fungal keratitis? It is the filamentous fungi, Aspergillus fumigatus. Okay. Now, for that, what is the drug of choice? For Aspergillus fumigatus, yes, it is topical natamycin 5%. Okay, natamycin 5% eye drops. So that is the drug of choice for fungal keratitis, and that is the only FDA approved drug. Whatever else we are using, they're still not FDA approved, although they work, they're not FDA approved. Is that clear? Okay. So the other options that I had given was topical amphotericin B. Yes, topical amphotericin B is the drug of choice for candida fungal keratitis. Yes, it is drug of choice, but it is not FDA approved. Yeah. Topical voriconazole 1%. Yes, it is. It works very well for fungal keratitis, especially for the resistant cases. Yes, we do give, but again, not FDA approved. Then topical capsifungin, one of the echinocandins, which can be given, but again, not FDA approved. Now, next one, which of the following is associated with active viral replication? See, the concept is when there is an active viral replication in the cornea. Yes, the virus loves epithelial cells. Okay, its favorite food. We ask us, no? You ask each other, what do you like the most to eat? What is your favorite food? So if you ask the virus, what is your favorite food? It will say, I have two. One, epithelial cells, and it also says my special diet is nerves. Yeah, my special diet is nerves. Like some of us, we like to eat calamari, or you might say, I love Brussels sprouts, or avocado. So something like special. So it loves epithelial cells and it loves nerves. Okay, it's exclusive special diet. So it destroys both the epithelium and the nerves. So when the epithelium is destroyed, what is the definition? Any epithelial breakdown is an ulcer. Yes. So when you have a superficial ulcer, viral ulcer. So both your dendritic ulcer and your geographic ulcer characterized by active viral replication. Is that clear? Yes, very good. Epitheliotropism. Very good. So the options are disciform keratitis, nummular keratitis, geographic ulcer, mycotic keratitis. So you either look for dendritic ulcer or geographic ulcer. So here option C is geographic ulcer. So the answer is geographic ulcer. So the question was, which of the following is associated with active viral replication? So it is geographic ulcer caused by virus. Next one, neurotrophic keratitis is associated with damage to. See, I've told you neurotrophic. Take the T. Okay, so there is a neurotrophic T. So which is the nerve which starts with T? Now you shouldn't tell me, ma'am, trochlear nerve. Trochlear nerve is a purely motor nerve. Okay, so that T nerve which is supplying the cornea, the trigeminal nerve. So when you have damage to trigeminal nerve, there is going to be neurotrophic ulcer. Yes, so neurotrophic ulcer is because of damage to trigeminal nerve. Yeah. Now a whorled deposit, a whorled like a spiral, okay, a whorled deposit is seen on the cornea. Vision is 6/6, so that means vision is normal. Which of the following drugs is not a suspect in this condition? So whorled deposit means we are talking about cornea verticillata or your vortex keratopathy. Okay, cornea verticillata or vortex keratopathy, right? Now, which of the following is not a suspect in this condition? So amiodarone, yes, most common cause of cornea verticillata. Very good, Vinod. Yes, absolutely. Right? Netarsudil, yes, netarsudil also causes vortex keratopathy. Hydroxychloroquine, yes, it does cause. Isoniazid, no. Isoniazid, one ocular complication is it can cause toxic optic neuropathy. It can still cause isoniazid, but it cannot cause this one. Okay, it does not cause a vortex keratopathy, right? So our question was, which of the drugs is not a suspect? So we know amiodarone is, I should suspect, ask the patient if he's taking any drugs for the heart. The netasudil, then I should look, check his IOP and look, ask him, is he taking some, and is he on netasudil? Hydroxychloroquine, ask the patient history if the patient has rheumatoid arthritis or some dermatological condition for which he has been prescribed hydroxychloroquine. But please remember, as long as the vision is normal, you don't have to worry about cornea verticillata, because whatever drug, you can continue the drug, you don't have to stop the drug. That is the main thing. If the vision is reduced, hi med nerd, all right, so UK, no? Now, if the vision has decreased, then probably we might look for other things and the need to stop the drug. As long as the vision is normal and it's just vortex keratopathy, for vortex keratopathy alone, you don't have to stop any of the drugs. Yes, including amiodarone, because amiodarone is life-saving drug for the patient. So for the sake of cornea verticillata, you should not stop the drug. Okay. Now, and please remember, amiodarone, if the patient has reduced vision, probably look at the optic nerve. He might have toxic optic neuropathy because of amiodarone, in which case you stop amiodarone. Okay. But for cornea verticillata itself, please do not stop. The nerve typically causing Hutchinson sign. All of us love Hutchinson sign. No, Hutchinson, it always reminds me of the Hutch days when Vodafone used to be Hutch, and they had a fantastic ad. You know, wherever the boy goes, his pug will follow. He had a cute dog, pug. Nowadays, you don't have this ad. So those days, you know, you'd have all these billboards showing you the boy and this little pug. And that is when we all learned the pug. Yeah. So wherever the boy goes, the nerve, the pug goes. So similarly, wherever the nerve goes, which nerve? The nasociliary nerve. Wherever the nasociliary nerve goes, the viral particles will go. So the nasociliary nerve goes to the nose and the long ciliary nerve goes to the cornea. So the viral particles travel down both the branches of the nasociliary nerve. So that is Hutchinson sign. So if you see a herpetic lesion, a vesicle either at the tip of the nose or the root of the nose, then most likely the patient is likely to have corneal involvement. Yes? All right. Let's go to the next question. Layers inflamed in interstitial keratitis. Okay. See, interstitial keratitis, the definition is important. It is primarily a... Thank you, sir. Thank you. Good morning. Namaste. And thank you so much for your kind words. Alright, so layers inflamed in interstitial keratitis. See, interstitial keratitis, the definition is, it is primarily a stromal inflammation. Interstitium means stroma, yeah, substantia propria. In the absence of other layers inflammation, meaning other layers, no epithelial inflammation, no endothelial inflammation, nothing else. So only stromal inflammation. So layer, and I've given in bracket S, so layer or layers inflamed in interstitial keratitis, epithelium, stroma, endothelium, all of the above. And whenever there is an all of the above, you all have this bias to, you know, go towards that all of the above. No, it is stroma, only and only stroma. Okay, interstitial keratitis means only and only stroma. I'll come to your question towards the end, beta. Posterior polymorphic dystrophy of cornea may be associated with. See, posterior polymorphic dystrophy is a dystrophy involving the endothelium. Remember, posterior. So the posterior most layer of cornea is involved. There's no inflammation. Okay. So the definition of dystrophy is there's no inflammation, there's no corneal vascularization or degeneration. Now, in PPMD, you have, in the PPMD itself, on the cornea, you have donut-like lesions, vesicles on the endothelium. And apart from the corneal involvement, you can also have some involvement in the lens and also in the retina. So on the lens, it can be anterior lenticonus. There can be an anterior lenticonus in PPMD. And also in the cornea, in the retina, there is a what is called fleck dystrophy of the macula. Okay. So when you think of PPMD, on the endothelium, you have lesions and you have lesion on the, finding on the lens, which is anterior lenticonus. And you have to look at the fundus too, because the patient might have a fleck dystrophy of the retina. Is that clear? All right, so we've come to the end of the questions. Hutchinson's pupil is seen in oculomotor, not just the nerve palsy. See, whenever you have a raised ICT and intracranial tension and it compresses, there is an uncal herniation, okay? The uncus herniates, compressing the oculomotor nerve first, yeah? So when it compresses initially, what will happen is the pupillary fibers will be irritated. Okay, the pupillary fibers will be irritated and the pupil will be myosed. Yeah, and after that there is a lot of stretching, and after that there is no irritation. The oculomotor nerve will go into a kind of a palsy. So the pupillary fibers will go into a palsy. Okay, so then it will start dilating. That is Hutchinson's pupil. Yeah, so Hutchinson's pupil is basically seen in uncal herniation, not in third nerve palsy. It is seen in uncal herniation, not uncle. Okay, yes, right. Okay, so guys, so this evening we've got a lens quiz at 6 p.m. on the Telegram group, and tomorrow 11 I will see you here with the discussion of those 10 questions. And also, yes, you can join the test and discussion on the EyeMentor app. So you can click on the link that I've given in the video description. So you can take a free look at the tests first and then decide if you want to join us. So we have separate batches for INICET, NEETPG and PDCET. Okay, so let me know which one you want to join, so we can give you access to the free tests and then you can decide. All right. And what else? So there I put up questions for you both on Instagram and on YouTube, so you can take a look at the question. So yesterday's question also gave you the answer in the evening, put out the answer. So please attend those questions, okay, so that I can teach you more. So I will see you tomorrow at 11, guys. All right, so have a good day, all of y'all. Bye. Ciao.